All right, welcome. Today, we're going to put you right in the hot seat for a consultant-level surgical viva. I'll be your examiner, and we're going to work through a classic case, a liver mass. Your job is to navigate the diagnosis and management just like you would in the real exam. Ready? Let's get started.
Okay, here we go. Here's your case, and the clock is ticking. You've got a 50-year-old patient with that classic triad, right upper quadrant pain, fever, and jaundice. Now, the first marks you're going to earn aren't for naming the triad, they're for showing me how you approach the patient. So tell me, what's your first move?
Okay, so first things first. You're at the bedside. Walk me through it. I want to know the key positive and negative findings you are specifically looking for during your examination.
Fantastic, that's a really solid rundown. You've covered the critical signs of chronic liver disease, things like spider nevi, and you've also honed in on the specific abdominal findings. That's a great start. So with all that in mind, what investigations are you ordering next? And don't just give me a list, tell me why.
Okay, nice. A very comprehensive list. You see, this is exactly what an examiner wants to see, a logical progression. You start broad with your baseline bloods to check liver function and inflammation, you grab cultures looking for an infection, then you cleverly start to narrow things down with serology and tumor markers. And your imaging pathway? Spot on. Ultrasound first, then the CT for the fine details. That's systematic thinking right there.
So right now, the list of what this could be is pretty long, right? And in an exam, you've got to show that you can think in a structured way. So break it down for me. What are your main categories for a liver mass?
Right? This table here. This is your mental framework for the entire viva. You have got to be ready to talk about any of these. But given the patient's fever, where does your mind go first? Yeah, exactly. The infectious causes.
So, like you said, that fever and the pain, it's screaming infection, isn't it? And the two big players here are pyogenic and amoebic abscesses. So how do you tell them apart?
You know, this slide right here, this is pure gold for your exam. You have to know this stuff. The little clues in the history like diarrhea can point you one way, but really it's the blood cultures and the serology that are going to be your biggest differentiators. Okay, so while you're thinking about that, the CT report hits your desk.
Okay, now look at this. There's a lot of info here, but the absolute crucial phrase is air fluid level. What does that tell you? Gas, right? And gas means gas-forming organisms. That points you directly to one diagnosis over the other. So what's your final call? What's the diagnosis?
Correct. Pyogenic liver abscess. Perfect. But, you know, getting the diagnosis is only half the battle. The real marks, the place you really show your stuff, is in the management. So what are you going to do for this patient?
All right, let's get into the management plan. Walk me through it step by step. How are you going to handle this patient with a pyogenic liver abscess?
Okay, good. A nice, clean, stepwise approach. You resuscitate, you hit him with broad-spectrum antibiotics, and then you get source control. Percutaneous drainage is usually the way to go. But let's dig into that last point, number 4. This is a classic viva question, designed to see how you think under pressure.
You know an examiner is going to push you on this. When is just sticking a needle in it not good enough? When do you absolutely have to take this patient to the operating room?
And there you have it. These are your absolute red lines. You see, it's not just about the abscess itself, it's about the bigger clinical picture. If your first plan fails, if the abscess is too complex, if there's another surgical problem, or worse, if it ruptures, you're going to the OR. Simple as that.
Excellent. Now, before we wrap up, let's just quickly pivot to another one of those differentials from your list. It's a classic for a reason, and it's a total curveball if you're not ready for it. Let's talk about the hydatidic cyst.
Right, so this is a completely different beast, a parasitic problem, and its management is worlds away from a pyogenic abscess. For your exam, there's one thing you absolutely positively have to know about this, and that's its classification system.
Seriously, just being able to mention the WHIGG classification, well, it's one of those things that just makes an examiner sit up and take notice. It shows you're not just reciting facts. You actually understand the nuances of how these are treated based on what they look like on an ultrasound. And just look at how different this management is. You've got medical options, you've got this special pair procedure, and surgery. But notice, you're not just sticking a needle in to drain it like you would with a pyogenic abscess. In fact, doing that can be a disaster. We're talking anaphylactic shock and seeding the abdomen. It is a totally different playbook.
And that brings our Viva to a close. So here's the final and maybe most important takeaway I want to leave you with. Always, always keep a broad differential, even when one diagnosis seems obvious.
because a nasty tumor, a necrotic malignancy, can look just like an abscess. And forgetting to even consider that, well, that's the kind of pitfall that separates a pass from a fail. You did well today.